Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning, Saturday, April 18th. Thank you for joining us for the Wild Health COVID-19 update. As of yesterday afternoon, Worldometer reported 690,900 cases and 36,000 deaths in the United States, and approximately 2.2 million cases and 152,000 deaths worldwide. Data from the Financial Times shows a sustained decrease in new coronavirus cases in the United States and the United Kingdom, although the decrease in the United Kingdom may be confounded by testing, which has slowed down across the country. The daily death count continues to rise in both countries, but there are early signs that deaths may be peaking as well. Turkey continues to battle a severe outbreak with more than 78,000 confirmed cases, more than Iran had at the same stage. Turkey will likely surpass Iran's total count in the next few days. Japan is also struggling with a less severe but growing outbreak with more than 9,000 cases. In U.S. news, the outbreak in New York continues to show signs of slowing down. In his daily briefing, Governor Cuomo reported that 630 more people had died from coronavirus in the past day. This is slightly higher than the 606 deaths the previous day, and bringing the total death toll in New York to 12,822. However, the number of hospitalized patients has dropped by more than 1,500 since Monday. The 3-day average of hospitalized patients fell for the third straight day by 3%, its sharpest drop yet. Despite these promising signs, Governor Cuomo warned New Yorkers that it is still too early to ease restrictions and that the state could not fully reopen until more widespread testing was possible. On Thursday, the White House released a set of guidelines for reopening the country on a state-by-state basis. You may have seen, and we've talked about it before, the American Enterprise Institute's guidelines and roadmap for reopening. These guidelines were similar. The guidelines echo reports that have been compiled in the last few weeks that emphasize case levels and hospital capacity as key indicators of when to begin easing restrictions. Specifically, states should not reopen until they have a sustained decrease in new cases for at least 14 days and can ensure that hospitals will not become overwhelmed and have the capacity for robust testing, particularly for healthcare workers. Now, that 14 days is an important target. And if you remember when I just talked about the New York numbers, there was actually a tick up in deaths today in New York. So that 14-day target may be difficult depending on how it is defined, whether it's new cases or deaths or how they define it. It seems like they're defining it as new cases. So we have to see what that means state by state. And it's important to remember that these are guidelines. The states themselves will come up with their actual protocols. Now, the last point about robust testing, that's drawn particular concern as public health experts warn that the majority of the country is not equipped to conduct the level of testing that would allow Americans to safely resume public life. Epidemiologists warn that most communities face significant barriers to conducting widespread testing, including supply shortages, stringent criteria for who can be tested, and a lack of high-quality antibody tests.
Yeah, I mean, I think in order to do this, we have to be able to test and trace. And in order to test and trace, you have to be able to test pretty much everybody. And I don't think we're there. I don't think we're close.
Yeah, the first part of test and trace is test. so we got to be able to do that part, and we're just not yet. Capacity, it seemed like it was increasing, but then at the same time, we're just, I don't think we're even close. Most estimates I've seen that say we need to probably double and triple at least the amount of testing capacity that we have right now. And the antibody test, an important point to note is it says a lack of high quality antibody tests is a concern. I am contacted daily by people who have antibody tests. Just a couple of days ago, someone contacted me and said, "Hey, we've got 300,000 antibody tests from Switzerland." The issue is that in mid-March, the FDA loosened regulations on what they required for antibody testing to be approved. Not the same requirements as before, but then the market was kind of flooded with bad antibody tests. Faulty tests, and then also tests just with poor operating characteristics. So the FDA has kind of pulled back on that and changed their stance a little bit. They're still giving guidance on that, but there are a lot of bad antibody tests out there. And we've probably mentioned it before, but if you have an antibody test that is 80% specific, that means if you get 100 positives and you tell 100 people that they're immune, even though we're still defining exactly what that means and for how long, then 20 of those 100 are going to think they're immune, and they may do risky behaviors, or they may actually catch SARS-CoV-2 and have a bad outcome. So it's got to be not just adequate testing, but adequate high-quality testing with good operating characteristics, and we're not there yet. Hopefully we're making progress, though.
And something that I don't think we've really mentioned on the podcast before, Matt, that you may know better than I do, but at last count, there was 30 million uninsured Americans. So that's presumably 30 million people that are likely going to have difficulty paying for this testing. So how are they going to get tested? I mean, every country that we've seen successfully perform test and trace has some sort of universal healthcare system. I'm not sure how our capitalist healthcare system is going to be able to manage this.
Yeah, we've got to solve that problem. I mean, we have spun up testing in our lab. We have antibody testing for our patients and coronavirus testing for our patients. But for the general population, this has to come from the federal government, in my mind. The states hopefully can help quite a bit as well, but we need a concerted effort and a coordinated effort from the federal government to be able to do the testing that we really need to kind of open back up and get back to work and play.
I spoke with someone recently. It was another healthcare worker who has insurance, but hadn't met their deductible yet, and they went to get checked out to make sure that they could go to work because they were sick, and they wanted to make sure that they didn't give coronavirus to their patients. And they ended up with a $1,200 bill, even though they have insurance, because they hadn't met their deductible. I just don't know how that's. I don't know how we can go about fixing this problem. It's just such a beast. But obviously, somebody hopefully who gets paid more than us can figure it out.
Yeah, we because we have testing. I spoke with a fire department and offered kind of just to do testing for free for them, and they told me stories of going to the emergency department to get testing and getting gigantic bills because of that and having co-pays. And it's just, it's a total debacle now. There needs to be some sort of organized effort, and now I feel like we're just complaining instead of having
fair enough. But somebody's got to talk about it. Instead of complaining, why don't I tell you about an interesting article that I read? So there was this article in the New York Times released on the 16th. And it was basically about the link of obesity to the severity of coronavirus disease. And you and I kind of alluded to this when we were talking about the higher number of young adults that we're seeing having critical illness in the United States as compared to Europe. This was on the podcast that was released on Thursday. If you want to go back and listen to that, it's a brief update. So this article in the New York Times basically talked about how there's multiple studies that have identified obesity as an important predictor of severe coronavirus illness, and especially in younger patients. Now, lots of different hypotheses as to why this could potentially be the case. Things like, for example, these people have other comorbidities. If you're obese, you're more likely to have high blood pressure, cardiovascular disease. There's the potential link of obesity and inflammation. And also just the larger you are, the harder it is to breathe. So you've got decreased respiratory function. You can have compression of the diaphragm. All of these are possible reasons. Realistically, we don't know exactly why there is a link between the severity of disease and obesity, but study after study is showing us that it's particularly there, and maybe very important for the United States because approximately 42% of Americans have obesity. So this is going to be a problem that is very likely unique to our country. There's been 3 studies that I reviewed. I have looked at this. The first one was in 393 COVID-19 patients that were admitted to New York Presbyterian Medical Center. This is in Lower Manhattan. They found that of the people who were admitted and under the age of 54, half of them were obese, where if you look at the overall population of New York, only about 22% were obese. So there's a disproportionate number of obese Americans getting admitted to the hospital. Other studies, one released on April 9th, obesity in patients younger than 60 years is a risk factor for COVID-19 hospital admission. This study looked at patients less than 60 with a BMI between 30 and 34 and found that they were 2 times more likely to be admitted to the critical care unit. And then they looked at patients who were under 60 with a BMI greater than 35 and found that they were 3.6 times more likely to be admitted to the critical care unit. Another study released on April 11th, factors associated with hospitalization and critical illness among 4,103 patients with COVID-19. This was New York City, basically patients that were admitted during the month of March, a single academic institution. They found that the third most likely reason to or most likely predictor of hospitalization was actually a BMI of greater than 40, with a 6 times increased risk of hospitalization due to COVID-19 by having that BMI greater than 40. The 2 higher than that was age greater than 75 and age greater than 65. So it's pretty much of pre-existing conditions. You can't change your age, right? BMI was the most important one for hospitalization. So really, really strong data coming out suggesting that BMI and obesity is extremely important, not just for contraction of the disease, but also for the severity of disease, hospitalization, and critical care admission.
Yeah, and what does this mean? I mean, can you drop 50 pounds if you're overweight in the next week? You can't. So we're not just saying, hey, you're in trouble. This is not something that's going to go away this month. This is probably, if you look at kind of the 1918 pandemic, there were 3 different spikes. This is probably going to come back later, especially as we open up. This is going to be a waxing and waning thing for a while. So we're not trying to make you feel bad. We're just trying to give you some encouragement. If you are overweight, you still got time. You can do something about it. And there's going to be a pretty big benefit for you probably.
I've talked to a lot of patients who have, taken this quarantine as an opportunity to kind of throw their diet out the window and throw their exercise plan out the window because, they don't want to have to worry about that stuff with everything else going on and the stress associated with quarantine and teaching kids at home. And now is just not the time to do that. This is the time to try to find that little moment of time during the day that you can get away to exercise. This is the time to focus on what you're cooking in your home. This is a great opportunity to take your health and make it the number one priority in your life.
Well, Mike, you haven't seen me in person for a few months, but in the first few weeks of this intensity with the pandemic, when I kind of cut back on intermittent fasting, wasn't working out as hard, I gained about 7 or 8 pounds.
Yeah, I could actually hear it in your voice.
You could hear my voice, yeah. And my vocal cords had a little more padding around them. So I actually realized, look, if this thing lasts for a few months, this could be a problem. So I kind of refocused myself and lost a few of the pounds. So it's a good time to focus on that. It's always a good time to focus on your health and optimizing anyway. What I didn't mention earlier about antibody testing, we have done kind of a deep dive into these antibody tests, this serology testing. We're still finishing up. It's not complete, but we're going to go over that as part of the webinar that we do on Wednesday. So this coming Wednesday on April 22nd at 5:30, if you want to be a part, we're doing a webinar. We gave a presentation yesterday to several groups, pro sporting groups. We've been engaged by some pro sports leagues and also some companies that want to kind of go back to work eventually on helping them develop some protocols. We are working on that and we want to share it with everyone. So we're going to have a webinar where we discuss and people can ask questions and comment. So if you go to wildhealth.com, you can sign up for that webinar. We're going to have some other guests other than just ourselves on the webinar as well and other experts. So go sign up for that now if you want to talk about protocols and how to safely get back to work and to play. A big part of that is going to be testing. Other components are just going to be social distancing, like the total numbers that are safe versus not. We'll go over some statistics and epidemiologies to help come up with plans for how many people could safely get back together at a time, depending on prevalence in the population in that area, what the local factors are like, the demographics of those wanting to gather. There's a lot of factors to consider, so we want to discuss those. And as we're coming up with plans, we think talking about this in public will help us make those plans even better as we get more opinions and questions. And part of that discussion will be the different brands of serology testing, what the sensitivity and specificity are and operating characteristics, and which ones you can use, which ones are more difficult to use, which ones are easier. So if you're trying to make those decisions around testing, antibody testing, return to work, return to play, join us for that webinar on April 22nd. You can sign up at wildhealth.com. Thanks for listening, and we'll have another podcast for you tomorrow morning.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.